Ya Palangina, Pangana Ian Anderson, Palawa Trawala, Parabana Trawalawe, Plamamarna, Katumana Mane Ine, Warandri, Bunarang, Tiana. So I'd like to welcome you all to this Congress. My name's Ian Anderson. I'm on the advisory board for the Australian Global Health Alliance, and it's my privilege to open up the conversation today. I started my acknowledgement of country in Palawakani. Palawakani is a language that was spoken by Indigenous Australians in the Bass Strait Islands in the 18th century. It's a reconstructed, rebuilt, reclaimed language. And the country I was speaking from is a place called Tebrakana, where my I have ancestral links, and actually was present on Tebrakana just over the weekend. It is my spiritual homeland and spiritual homeland of the Parabana and Trawalawe, and close to the clan groups of Plamamarna. I'm here on the land of the Wurundjeri people and the border between the Wurundjeri and the Bunurong people, and I just wanted to acknowledge their presence, their ancestry, and their long-going traditional ties to this country. A welcome to country or acknowledgement of country is done in the spirit of reciprocity. It's a very time-honoured tradition, and it recognises both place and country and the calling of the ancestors. Over the weekend, I was in northern Tasmania at a cultural gathering that acknowledged a number of key ancestors to my people, including a guy we call the grandfather, or Mananagana, who led the tribal encounter with the Europeans and British in the early 1800s. The kind of, I think that moment is a bit of a metaphor for global health and some of the contemporary challenges in the field of global health. We were on the northeast tip of the island, looking, and when you see from Lutruwita, when you see that island and look north, you can see the Bass Strait Islands, where Aboriginal women were taken by force and by other means to work with the sealing community during the 1800s as sexual labour. And Palawakani was a women's language that was derived from the languages of northern Tasmania and Gunai language of Victorian, some South Australian language, as was the women that women spoke, so that they could have a conversation without the white menfolk who had taken them, could hear. It's also a metaphor for some of the really contemporary challenges, I think, in the global health community, as we rethink and reconfigure what global health means in our contemporary world. We were there for tens of thousands of years, and in our communities, in the northern side of Tasmania, people always had an understanding of how they came to what became an island over a 10,000 year period. And that was pretty simple. We walked from the north. There was no metaphorical history. It was actually a very prosaic history of coming and walking from the south, but always being present and acknowledgement that we're part of a broader global community, although somewhat disconnected from that community. And in the 1800s, my people in the north of the island were very, very aware of the globalization and the kind of the reach of the North into our backyard and what that meant and how we suffered from that during the colonial period. So in Tebrikana over the weekend, it was a very warm and welcoming environment, but was a way in which we were consciously thinking about how we, in the Deep South, reach out to the metaphorical North in ways that are collaborative, in ways in which we had power to work in that relationship. And that is one of the threads I think will be picked up today in the conversation about the decolonisation of global health and how we might learn to work in a very different way to the communities that we want to engage with. So on that basis, I want again to say welcome to this conversation. And to finish off, and in the spirit of Palawakani, Walika, thank you and welcome to this event.
Thank you so much, Ian, for that beautiful acknowledgement and welcome. Good afternoon, morning or evening, wherever you are. I'm Selena Namchi-Low. I'm the Executive Director of the Australian Global Health Alliance, Australia's peak body for organisations working in global health. I speak to you from Melbourne, and where I am is the land of the Wurundjeri people of the Kulin Nation. I pay my respect to elders past and present. On behalf of the Alliance, I welcome you to this year's Congress themed Global Health Diplomacy. We're delighted to be in partnership this year with the Australian network of 53 WHO collaborating centres, whose secretariat we proudly host. Thank you very much for joining us. With people calling in from all over Australia, the region and the world, from Kabul to San Fran to New York to Geneva, Stockholm and Manila, Jordan and Port Moresby. Thank you so much for giving your time and trust to us. While I hate to guarantee anything in 2022, I can assure you that your time will not be wasted in the company of those you will engage with here online in this space. The Alliance was founded in 2016 by global health organisations in Australia to support and strengthen the global health ecosystem in their common aim towards health equity and sustainable development. We're a very diverse membership alliance of universities, global health institutes, government entities, NGOs, think tanks, and public-private partnerships, and other networks in global health who work collaboratively with us to be stronger in partnership. We're strategically committed to planetary health, specifically climate change and health security, gender equality, and supporting an enabling environment for global health innovation and research intergenerationally. We're possibly the first OECD country-led alliance in global health who, as Ian mentioned earlier, had First Nations global health equity as one of the foundational mandates. We're certainly among the first whose leadership have intentionally and very recently stated to work together to shift power in global health towards justice and equity in our region and beyond. We host not only the Collaborating Centre Network of WHO, but also Pacific Friends of Global Health, a partnership of Gavi, Global Fund and Unitate. Both these ecosystems have had an extremely busy year. And just to quickly highlight two key events, the network launched the world's first WHO Collaborating Centre Capacity Mapping Report. And the fact that we're home to 53 of the 800 collaborating centres worldwide is testimony to the excellence of the global health sector in this region. Pacific Friends hosted a high-level visit from the Global Fund and will be hosting again very soon in January an MP trip to PNG. All these global health diplomatic platforms together with the Alliance need your support and attention because they all make our work here more relevant, harmonious and stronger globally. The global health challenges, as we have seen recently with climate change and the ongoing pandemic, require complex analysis and collective action. The Alliance and all its networks work on those issues we can do better together rather than alone or apart. And we collectively work to fill gaps in our own ecosystem by trying to listen to members and building platforms to achieve common goals. This year has been rich. Our ecosystem of ecosystems has never been more active and relevant in regional and global health changes, from pandemic treaty to First Nations-led foreign policy to cutting-edge research and innovation for new emerging diseases in global health and solutions for non-communicable disease burden and the climate crisis to our expertise in child and adolescent health. Alliance members and the network of collaborating centres individually and together are world-class leaders in global health. We work not only with you, the global health community, but with all of our partners internationally and in the diplomatic and government circles, such as the arts, to raise awareness, and with wider corporate community. This year, we've been working on several new platforms, including a possible Parliamentary Friends of Global Health. We saw our very first Global Health Film Festival with Global Health Film in partnership with many of the members here, Vic Health, the Australian French Research and Innovation Association, Monash Melbourne University, Nossal Institute, and the Australian National Uni. We also set in motion an intentional commitment to work more with young leads in global health by partnership for platform opportunities. We continue to contribute to a number of government platform processes, but as we know, timing is always of essence in global health. While we here at the Alliance were working on how to integrate our work and be more relevant in, as Ian mentioned, the global decolonisation of global health dialogue, aligned with some of our eminent First Nations global health leads here, the government was launching its new statement on foreign policy, which places partnership and First Nations-led foreign policy at its very core. So this leads really well into the theme of today, global health diplomacy. Who, why, and where to? Some of you might think, what a dry topic for a Congress, but that in fact, I think was likely pre-pandemic thinking. I think most of us in 2022 recognise global health in all its processes, but also its assets, including diplomacy, are part and parcel of planning well for future threats and opportunities by specifically taking opportunities of the natural linkages we have, but making new ones between themes, countries, and ultimately people, whether they be researchers like some of you, problem solvers, policymakers, or individuals with creative design minds for a fairer future world. So this afternoon, we're delighted to share the Zoom stage with an incredible set of speakers who've made special time, some at an ungodly hour around the world, to share their wisdom and ideas. We're joined by the excellent team of Jesse McGee, who will be doing a visual graphic. Our agenda is as follows. We aim to not only discuss the world and work of global health diplomacy, but bring forth the reality that this is work that is shared agenda and responsibility. So first, a keynote speech from Dr. Gooseby, followed by a short recorded intervention from Dr. Pate, who's on a plane right now and couldn't be with us in person, followed by a panel discussion on global health diplomacy with speakers from WHO, civil society and international NGOs, moderated by Dr. Stephanie Williams, Australia's Ambassador on Regional Global Health Security. We will then break, to be followed immediately after by a short talk by Renzo Guinto and a panel session engaging First Nations scholars, researchers and youth voice. Finally, absolutely delighted to have Anders Nordstrom, Sweden's Global Health Ambassador, sharing his future reflections and horizons work with Dr. Hayley Jones, the Director of the McCabe Centre for Law and Cancer, which is also a WHO Collaborative Centre on Law and NCDs. We want this to be as interactive as possible, so we allocated generous time for Q&A, and you can pop your questions in at any time so that you can engage with all of our speakers. Thank you so much for your time and trust to us. And if any of the speakers or audience have any tech issues, please just pop it in the chat to our behind the scenes Zoom team who are administering the platform. They should be able to help you. So without further ado, I have great pleasure in introducing our esteemed keynote speaker for today in a moderated conversation with me. Eric Gooseby is a leading global health expert on infectious diseases, specialising in HIV/AIDS clinical care, research and policy. He's the director of the Global Health Delivery and Diplomacy Institute for Global Health Science at the University of California. From 2015 to 19, he was the UN Special Envoy on TB, appointed by UN Secretary General Ban Ki-moon. Previously, he was Ambassador at Large and the US Global AIDS Coordinator, Assistant Secretary of State under the Obama administration. He oversaw the implementation of the President's Emergency Plan for AIDS Relief, called PEPFAR, and founded and led the State Department's Office of Global Health Diplomacy. Eric was also CEO and Chief Medical Officer of Pangea Global AIDS Foundation. During this period, he played a key role in HIV/AIDS national treatment scale-up plans, South Africa, Rwanda, China, and Ukraine. And as a declaration of my conflict of interest, Eric was my clinical mentor at the Clinton HIV/AIDS Initiative and someone whom I have personally seen in great action as a global health diplomat extraordinaire in all levels of government, globally, nationally, in health boardrooms, and also, and most importantly, his extreme commitment to patients under his care. We really couldn't think of anyone better to introduce this huge but important topic to this audience, and we're extremely grateful for your time, Eric. Welcome to our community.
Thank you, Selena. It's a real honor and a pleasure to be here with you tonight. So my pleasure.
Thank you. So I'd like to start with an easy question for you. What does global health diplomacy mean for you? What definition do you use? And please, can you share in the context of your work today and past?
Certainly. Well, thank you again. This is a wonderful convening and a timely discussion. I think diplomacy to me has described the ability of sovereign nations to formally engage with one another in the areas of health. And this generally means understanding the burden of disease in their country and their region, understanding how it impacts their own population and populations around them, and have a quantitative understanding of the response that the respective municipalities, provinces, and countries have been able to mount. Putting it at a diplomatic level allows for governments to not only communicate with one another, share analyses and responses, but also to understand that there's a shared responsibility and a need to understand inequities in that distribution. And governments are in the best position to do that. So for me, health diplomacy really encompasses the ability to talk between nations, within nations, about the burden of disease, the response to it, and a move toward a collective response coming out of it.
Thanks very much. I mean, you didn't start off your career as a global health diplomat, as we know, and to be a global health diplomat is really a specific kind of skill set. Would you care to share how you came into this work, but also share with us, in your opinion, what kind of skill set or talents do individuals or even organizations need to navigate the multidimensional challenges in global health?
Well, for me, I started as a physician responsible for direct patient care. That was always the orientation I had in my understanding of what I was seeing. It was the lens through which I saw things and the lens through which the response was evaluated. I think that basic commitment and understanding that patients, those who need and seek your services as a health provider, as a physician, are always assuming and need to assume that you, as that provider, are doing things in their best interest all the time. That core commitment and the trust that comes out of it has got to translate to not just patients, individuals being seen one at a time, but also in populations. And I think that global health and the discussion really is at the population level and the response at a population level. But that diplomatic context puts a line of accountability in it that is unique to global health.
Thanks very much. Apologies for my dog in the background. Can you share with us some what have been some of your biggest challenges? For example, you know, were they in terms of working cross-sectorally outside of the health sector, or just even at a country level?
So I guess the biggest challenge has been engaging in dialogues with ministries of health and private sector responses in countries that define a continuum of care and services that are based on either guideline assumptions, recommendations as standards of care in their country, or they look at multilateral standards of care as their guide. And comparing that to the continuum of care that they have stood up in their country and seeing discrepancies in what guideline standards of care say should be done for a given population at a given time, and what they have actually stood up and are implementing in their clinics and hospitals. The awareness and ability to talk to those disparities has been frustrating. The willingness to see them as something that needs to be closed or revisited once new guidelines and standards are presented, and tuberculosis is going through that right now in a big way with new treatments, shorter treatments, less side effects, more effective treatments for MDR and XDR TB. But HIV, its entire history, is one of coming up with new therapeutics that meet and are needed in a population that may or may not have a up and running medical delivery system to meet that person and give them the services that they need. And the ability to understand where your implementation effort as a government, as a foundation, or as a multilateral needs to be focused to complete that continuum of care. Having a coherent conversation about what are you saying you should do to every patient with this disease in your country, your continuum of care and services, and then what's the reality of what you're doing compared to the outcomes you're generating. And that discrepancy, or being completely on point is where the discussion should start and end. That's been difficult to maintain.
Yeah, no, thank you. That actually leads really well into my next question. There's quite a lot of assumption that in global health diplomacy, or in some fields of it, that negotiations are made not to disturb a status agreed quo. So, you know, and in terms of negotiations between countries or between different stakeholders on various platforms. Ian earlier mentioned that the decolonisation of global health dialogue and the space needed to have more voice in global health discussions. Is there room for dissent in global health diplomacy? I mean, and how have you seen that borne out where there has been conflict? You mentioned it a bit in just that later summary, last summary.
Well, Selena, I really think there is not only room for conflict, but it's the necessary path we need to take as a global health community to better responding to the unmet needs that we already know about. I think that the clarity that we need to put in our discussions about met and unmet need, about populations that access those services and populations that don't access them, what are the begin to define the social determinants of health for that individual and that population, and getting a awareness of that in the ministry and in the political arm that funds those priorities as defined by the ministry or the processes that they put together to determine what that continuum of care should be, becomes the challenge. When you add private sector, when you add community-based organizations that are implementing a large percent of the effort, that do not have a central line of oversight, you see dilution of the accountability in the system, and you remove the ability for that system to self-correct with each budget period, with the conversation loops closed about what worked and what didn't work for which population. Now, that all is predicated on a surveillance system that is robust, but it's not difficult to set up. It can be set up very simply with persistence, but with knowledge. And I think once the data from that information system starts to be used, people get much more invested in making sure it's accurate. But I believe it's going to reinvigorate lines of accountability that with the delivery systems we now mostly stand up, we have lines of accountability that some go back to the local setting, the provincial or the country priority policy setting process. But too often, the priorities and the funding decisions are made in capitals thousands of miles away that never really hear the outcome data that this year's funding created, and do not get the opportunity to change the priorities that were funded in year one to what they should be in year two, to change the outcomes in an agreed upon manner, to engage those that did not or persist in a disparity. That self-correcting governance process is very rarely instituted because of the complexity and decentralization of the responsibility. When you add private sector into that, you add a confounder that further removes your ability to control who, what, where, and when in any given moment. And I think the COVID challenge and threat that was presented to all of our delivery systems really highlighted that disconnect.
No, thank you so much. I might leave some of the questions for the panel discussion afterwards with Dr. Williams, but just a final question from me. In your view, what is success in global health diplomacy? At what level is it best defined? And do you have an example that you look up to?
I have many examples of the following, I would say, lines of accountability being reinvigorated. To me, success is when the burden of disease is understood for a specific population, and that is made up of individuals, and that the delivery system accurately identifies, enters, and retains those individuals in the care and services that they say they've stood up, that they understand differences in the population in accessing those services, and understand the relationship the access has to creating an outcome that they're measuring. When all of that is in place, the outcomes begin to feed the success or failure of the priorities and decisions you've made to fund in that budget period, and are the topic of discussion for the next year's funding. When you are able to stand that up, to me, that is a successful self-correcting system that will keep the priorities connected to the needs of the population, more constant, more steady in that, without deviation. And if the government and civil society see themselves as having specific roles in the integrity of that system, it can last and keep giving for many years. And I think we see examples of that in the HIV community when you go from one country to another. As these principles kind of come into a given country, you see an improvement in utilization, in identification, in retention of the populations at risk. You see a appreciation of different access and retention patterns that demand that the delivery system accommodate. And your surveillance is such that you know when you've done it.
Well, thank you very much, Eric. Eric, you'll be staying with us for throughout the Congress, I understand. So we can partake of your wisdom in many different sessions as well. I'm going to ask that the audience save your questions for Eric for the panel that's going to follow. And I would like to now ask to play a recorded intervention from Professor Mohammed Ali Pateh. Mohammed Pateh is currently the Julio Frank Professor of the Practice of Public Health Leadership at the Harvard Chan School of Public Health. He's the immediate past director of the Global Financing Facility for Women, Children and Adolescents, and the Global Director for Health, Nutrition and Population, Global Practice of the World Bank. Dr. Pateh has previously held several senior positions, including that of Minister of State and Health in the Federal Republic of Nigeria. and he was the Chief Executive Officer of Big Win Philanthropy based in the UK. So we're going to hear from Mohammed because he is on a plane right now.
Global health diplomacy encompasses the set of multi-level, multi-stakeholder negotiation processes that shape and manage the global policy environment for health. These are processes through which actors shape priorities, allocate attention and resources, manage losses, and dispense accountability. In essence, global health diplomacy is the art and science of global health politics. While traditional diplomacy among nation states had focused on issues of security and trade, the evolution of global governance in our times has brought together a disparate set of actors beyond nation states into the arena for setting global agendas and negotiating resources, as well as resolving conflicts. Governments, bilateral and multilateral organizations remain at the core of the global system, but increasingly, a diverse set of actors, such as the private sector, philanthropic foundations, civil society, and academia are exerting their voice and influence, especially in global health governance, mostly through their use of tools of soft power. In this complex landscape, where national domestic issues intersect continually with global health agendas on multiple fronts, actors are constantly jostling and adapting to represent their interests through global health diplomacy. However, there is a set of structural asymmetries in global health that often distort the scope, nature, and fair resolution of the tensions that exist in global health. This include asymmetries in legitimacy, resources, capacities, and networks. The balance of power tends to favor the powerful, wealthier, and more connected actors and interests. There are many illustrations of these imbalances, from wealthier bilateral entities dictating priorities where they may lack the legitimacy and cannot be held to account, distribution of resources to home-based institutions for research and implementation in poorer countries, undermining sovereign policies and regulations, shaping markets by undeclared corporate interests, to visa restrictions limiting voices from parts of the world from attending global health dialogue on issues that are directly affecting them. The still ongoing COVID-19 pandemic has brought to the fore the importance of global health diplomacy. In the face of the crisis, we had seen rising nationalism and acts of unilateral self-interest from some countries, at least in the earlier parts of the pandemic. Emerging out of the ashes of the pandemic, the global community must now strive to build a better, more secure, equitable, and resilient world. As we recently put in our report of the task force of the Lancet COVID-19 Commission, there are a set of core values that we must imbibe going forward. These values include solidarity, the idea that together we are better. Within nations, this solidarity is an awareness of the multiple and intersecting forms of inequality that breed injustice and unnecessary suffering for the poor, for the socially marginalized, for racial and ethnic minorities, for women and girls across social categories, and for refugees and the displaced populations. We ought to hold a most basic form of solidarity, that of an open and mutually respectful appreciation of our differences, and a commitment to the peaceful resolution of those differences where there are conflicts. The most vulnerable individual members of societies and countries should have prioritized consideration and attention. The second value is that of equality in dignity and rights, that national and multilateral efforts in global health must ground themselves in the human rights principles and the norms that have generally been accepted by the international community. The Sustainable Development Goals, SDGs, were conceived and couched in the language of human rights, and they have been subscribed to by 193 countries. Therefore, upholding the protection of human rights as a foundational principle in global health arena simply means holding nation states at their own words. The third value is that of transparency, free flow of information, and commitment to the truth. That we uphold a commitment to free flow of information within and between countries. That we strive to discover and speak the truth always, and that actions should be based on the best available information. In this era of hyper-connectedness and media, we must protect freedom of information while at the same time be watchful to counter disinformation, misinformation, and falsehoods. The values of academic freedom and open scientific inquiry must be upheld and shared widely, not only from one part of the world to the other. Fourth value is that of focusing on health before profits. That in the multi-level, multi-stakeholder nature of global health, with constructive private sector participation and numerous public-private partnerships that are driving innovations and new tools, generating huge intellectual property, wealth, and also life-saving interventions, we must adhere to the value of putting human health before profits. And finally, the value of multilateralism itself, that there is no good alternative to multilateral approaches to solving our common, complex, interlinked challenges in global health. We need to reform the multilateral system with a stronger focus on the composite country units, empowering them, enabling voices to speak equally for the poor as well as for the wealthy, holding each other accountable, including countries and their leaders, and considering federated multilateralism as an approach with regional bodies, as we've seen with the African Union in the COVID-19 response through the African Centers for Disease Control. These universal values should guide states, international organizations, civil society actors, philanthropists, scientific research bodies, and the private sector in the conduct of global health diplomacy to lead to a more equitable, inclusive, safer, and healthier world. Thank you.
Thank you very much to Dr. Pate, who sends his regards to our community. I now have the honour to introduce Dr. Stephanie Williams. Stephanie is Australia's Ambassador for Regional Health Security, facilitating Australia's advancement in the Indo-Pacific by creating links between Australia's public health and medical research experts and partners in the region. She guides the implementation of the Health Security Initiative for the Indo-Pacific region. She's a public health physician and epidemiologist, and she has been DFAT's Principal Health Specialist. Prior to joining the Department for Foreign Affairs and Trade, Dr. Williams was a medical advisor in the Office of Health Protection in the Australian Government Department of Health. She also served as Registrar for Victoria's Chief Health Officer and epidemiologist as in Global Health Security for the World Health Organization. She also worked for MSF, thereby making her the perfect moderator for this important conversation we're about to have together. Stephanie, we can vouch, is an incredible ambassador for health in this region, and we're really thrilled to have you here. Thank you so much. Over to you.
Thanks, Selena, and it's great to be here today. I'm dialing in from Washington, and this is on the traditional lands of the Anacostia people, the Nacotchtank people on the not far from the river where I am today. Now, we are still going on with the same headline topic for the Congress, global health diplomacy, what, where now, where next. And with Eric's presentation and then Mohammed's video, we've had such interesting and different perspectives of what and how they themselves interpret global health diplomacy, and really good examples. And we're trying to keep in this panel a really clear distinction between what we do in global health and what we do in global health diplomacy. We've got some examples about working in the best interest of population. Then we've had Mohammed talk about processes and multi-level, multilateral forums and resource allocation. And there's sort of huge array of things you can do in global health. And we've also heard about the importance of the breadth and depth of perspectives beyond the traditional centers of power. So what we're going to do in this panel, we have 3 practitioners with very different perspectives. And what we'll do is I'll ask them all to turn their cameras on. So we know Ying and Thomas and Jennifer turn our cameras on so we can see you. And we'll go in, they're each going to get the same question first off. And I'll start with Thomas and then go to Jennifer and then to Ying. And the question I've asked each of our panelists to answer, and I'll just give Thomas a chance to turn on his video because you're first up, is to define what global health diplomacy means in the context of your work and give an example of an event or issue that brings this to life. Now, I'll just give a brief introduction to, you have the full bios very generously provided by the Congress. And suffice to say, Thomas is the country manager of Health Poverty Action in Cambodia, long-standing regional advocate for HIV, AIDS and health in China and Southeast Asia. Especially for people living with HIV AIDS, and experience in a number of very relevant organizations and processes that about multilateral prioritization and resource sharing that Mohammed touched on before. So Thomas, can I start with your perspectives about what it means from where you're working currently and also in the past, with some examples of global health diplomacy in practice for about 3 to 4 minutes, and then we'll move to each speaker in that kind of forum. So over to you, Thomas.
Okay, thank you, Jennifer. And actually, I started my work on HIV/AIDS. It was like 20 years ago, and by that time, I was diagnosed as HIV positive. In China, I have nowhere to go. I just don't know what treatment is available, and then because of stigmatization, and I become isolating myself. We don't know where to go, and by that time, I was struggling with one question: should I spending $1,000 per month to taking the medicine, or save the money for the family? And I think the information sharing is we're getting the information very limited. And then by that time, the Chinese government, I remember one of the leader in 2002 early. He said that doesn't matter what the economic growth China is, the HIV treatment won't be free. And but the dramatically change was Selina Low set up the first MSF free treatment in Nanning City by the end of 2002, just a couple months later. And then in 2003, I was joining the ITPC treatment access campaign. It's a meeting in the Cape Town, and then I meet all the people from different countries, activists, NGOs, and also Global Fund people were there. And then after the Cape Town meeting, and the whole things will change. And by the end of 2003, just 1 year after that, and China started providing free HIV treatment for all. And all these things is like, I think it's a globally not just the government level, and also the community level, civil society level, working together across the border, and then to develop good strategy to making the life-saving measures available for all the people. Doesn't matter they are in developing country or developed countries. And I think this is very important to me. And also now I'm working in Cambodia. We can see that with the Global Fund and Cambodia, malaria almost get into the eliminate stage, and HIV treatment is on the way. Continue treating 70,000 people, and just like Eric just mentioned, that a lot of good practices, standard of care, and through all these kind of communication, Global Fund is a platform. They bring all the expertise and experiences and standards into the developing countries, and then aiming to improve the standard of care and treatment for the people. So health diplomacy to me is like the people from both government level and civil society level working together cross-border and making prioritize the health and the health of everybody.
Thanks, Thomas. That's a great introduction. And I really like the way you've just brought up the theme of opportunities to form alliances. That threshold Cape Town meeting that you described sounds like the start of something that, a snowball almost of people and communities gathering power as it comes down the hill. We're in question time, and I flag a question of interest for you to come back to after we do the intro remarks from Jennifer and Ying about your reflections on when you were on the Global Fund board in the communities delegation. I'd like to come back and ask you a question about that as we get into Q&A time. But let's move perspectives now, which is sort of shifting right on my screen to Jennifer Tierney, who's currently the Executive Director of MSF Australia, with huge experience in MSF in countries and in US and with a wide range of NGOs. And the full bio, of course, is in the flyer, which I urge you all to read, because I want to waste no time in history and talk to the present person on my screen and ask you, Jennifer, the same opening question about what, from your perspective in MSF Australia, what global health diplomacy means in practice, and some examples that bring that to life. Over to you.
Yes, first, just quickly want to acknowledge the Gadigal people, the traditional owners of the land on which I'm working and living today. So, in thinking about what global health diplomacy means for Médecins Sans Frontières, Doctors Without Borders, MSF, we are a giant health provider. As an organization, we're working in 70 countries around the world. We've got 60,000 team members helping to provide care. And so for us, global health diplomacy at the end of the day is really about pragmatism. It's a tool to help our medical humanitarian teams provide the best possible patient care we can for our patients. And so it is about bridging that gap and the disparity between what the guidelines say, as Dr. Gooseby was mentioning, and what should be the standard of care versus what we're actually able to supply for the patients that we treat. And I'm sure Selena and yourself and others have seen the disparity between, the level of the quality of care that we should be able to supply and oftentimes what we have available as tools on the ground. And so we're often calling out and putting real practical face to the inequalities and inequities that we see in the space. And so globally, we're a bit of an unwieldy beast as an organization as far as centralized governance is concerned. But so global health diplomacy operates at many levels within the organization and across many actors. The most well-known of our initiatives in global health policy is the Access Campaign. And the Access Campaign was created when we won the Nobel Peace Prize, and it was designed specifically to bring down these barriers that I'm talking about, making sure that drugs and tests and vaccines are available, affordable, suited to the people we care for, and adapted to where they live. And we also have an initiative called the Drugs for Neglected Diseases campaign, which is a very pragmatic Drugs for Neglected Diseases initiative, which is a very pragmatic partnering with the pharmaceutical research and global health sectors in order to be able to create solutions that we can use in the field to be able to provide our patients with a better quality of care. And so by bringing those pragmatic experiences that we're having on the ground and then creating initiatives around those experiences, we're able to dialogue at a broader level in the global health space. And so we also have our roots in HIV with the Access campaign. We were with Treatment Action Campaign and many others in Cambodia and South Africa on bringing down the price of antiretrovirals. And until last week, we actually released a press release calling on ViiV to urgently lower the price and publish the price of its really effective HIV pre-exposure prophylaxis PrEP treatment that exists, which is long acting, is a shot that can be given and cover people for 2 months and can really turn the tide against new HIV infections globally. The challenge is, of course, the intellectual property rights and the cost, creating that lack of access for our patients. And so we have a long history of advocating just by virtue of what we see. That's at the global level. On the local level, MSF also works, for instance, in Australia. When we were working on Nauru, we provided mental health care on the Pacific island of Nauru for 11 months before being forced to leave by the Nauruan government. And one of the things here that you're seeing is a real cross-sector of human rights and health equity, and how actual human rights policy coincides with global health. And so we've been advocating for the Australian government to stop its policies of offshore processing with an aim to actually improve the mental health and the healthcare for patients outside of its borders at this time. So we are very much in the pragmatism of the global health dialogue, and then trying to take those specific examples and then elevate them to influence global actors, whether it be in the medical research space, the pharmaceutical space, or the government or international space. And I will stop there.
Thanks. It's great to hear those perspectives of the global with specific focus campaigns, and then the the institutional decision to make sure what we see, you see at the field, is heard all throughout the organisation as a platform for raising issues. When we come back to questions, I want to flag one of interest to you now in terms of MSF in the past has been calling out issues perhaps ahead of when states have caught up, or multilateral organisations. And a good example was in 2004 with the artemisinin resistant, and calling out future crises. I'm going to come back to you and ask what you're seeing, what you're going to call out in the next couple of years to give us a flavour of what we should be looking for. But let's move on to introduce our third of 3 panel speakers, Dr. Yingru Jacqueline Loh, who is the current WR of the WHO office in Laos, having worked in several country offices at the regional level and at the global level and HQ, as well as a raft of infectious disease physician experience across the world. And it's really with that WHO hat on that we welcome you today for your perspectives on the question at hand, which is what global health diplomacy means for you in your role currently as WHO, one of the trickiest roles, I think, that exists in global health, in managing technical agency and politics, and some examples or recent examples of your deployment of some of these obligations of WHO. So over to you, Dr. Loh.
Thank you. Good morning, good afternoon, and thanks, Stephanie, for the introduction. I would like to really thank the organizers for having me here at the panel. Well, health diplomacy is really front and center to my work, in particular as a WHO representative. It saves countries, it saves communities, and it saves lives. And the COVID-19 pandemic we are emerging from really demonstrates how health is and must be at the center of issues we work to address. Without health, we have really nothing. And because of the global systems and world we live in, achieving many of the goals we set ourselves really requires international diplomacy, and we call it health diplomacy. Information sharing, reporting regarding biosecurity, multilateral and bilateral cooperation amid health crises, development of new medicines, vaccines, and equitable access. These are just a few of the ways diplomacy supports our health goals. And I would like to take the opportunity to thank partners in Australia and the Australian government for its strong leadership and support in Asia, and in particular in Laos, but also in Malaysia, where I was based before. It has a significant and meaningful impact. Since I'm asked what does global health diplomacy mean to me, I'll make it straightforward. It means bringing together public health law, and foreign policy with the goal of improving health. It means creating much needed opportunities for nations to work together across ideological divides to find common solutions to common problems. And it means partnership and collaboration with plenty of tact and negotiation. And of course, it involves critical convening institutions like WHO. We are at front and center of these situations. And I would like to give you an example of global health diplomacy in the context of my work. And I'm not talking about COVID-19. I would like to give another example, which just happened the year before COVID-19. In December 2019, polio cases were detected in Malaysia for the first time in 27 years. Concomitantly, we had a similar outbreak in the Philippines. In Malaysia, all cases were among unvaccinated children, and some cases were related to unregistered migrants. And you can imagine how sensitive this topic is. 18 months later, after the implementation of a successful public health response and a polio vaccination campaigns, in fact, several campaigns, the government of Malaysia declared the outbreak over, and same in the Philippines. But let me talk about the work behind the scenes. While the government of Malaysia responded admirably, and international mechanisms for and support were essential to swift conclusions of the crisis. So existing international agreements around disease outbreaks meant a coordinated global response. The right people knew at the right time. The three levels of the WHO had to work closely with the government to agree and take on actions to contain the outbreak. We needed careful micro-planning to help the government to conduct several rounds of oral polio vaccine type 1 and 3 campaigns in remote and very difficult to access villages all across the state of Sabah and Borneo Island. It's a vast geographical area sharing borders with the Philippines, sea borders, and Indonesia. And we have a history of illegal migration from the Philippines to Malaysia and to some degree from Indonesia. The vaccination campaigns included all children, irrespective of being Malaysian national or migrant, and international collaboration and diplomatic efforts were very, very central. And the vaccination campaigns had to be coordinated with the Philippines and Indonesia. They had to be synchronized. So teams of technical experts were deployed to support not only the campaign planning, but also surveillance and many other areas. And in particular, communication for health was critical to gain the trust of the communities, that families with unregistered migrants would not go into hiding with immunization from immunization teams from the Ministry of Health who were visiting for the campaigns. And last but not least, the no longer commercially available oral polio vaccine type 3 was donated from the WHO stockpile, which was not an easy request as supply was limited. So the Malaysia Immunization Program presented its progress to the WHO Polio International Health Regulations Emergency Committee, and was provided recommendations and guidance. And almost all the mechanisms I described required health diplomacy. They involve public health, law, and foreign policy. They involve tedious diplomatic negotiations, as migration is a sensitive matter, as you can imagine. So I'm conscious of time, so I won't go on, but I will just conclude with 2 points. These challenges, health challenges, and the others that exist have generated increased demand for diplomatic coordination and multilateral response as health threats impact our world. No country is safe until every country is safe, because infectious diseases, they don't respect borders. And similarly, addressing these challenges must not be the role of only the health sector. To achieve health for all, a lot more people, more sectors are going to need to be involved. Public health and foreign policy cannot be addressed separately. Thank you.
Thanks, Dr. Lowe. And if I can, I'm going to start by asking a couple of follow-up questions, because you really brought that example of the tri-country polio response to life, and not just the time it took, but layered the complexity of issues in terms of which populations needed vaccination for sort of common interest. I wonder if you could bring to life in a bit more detail how that actually took shape. So when you said we deployed experts to Indonesia, Philippines, and Malaysia, and the countries met often, was there, say, a standing health ministry dialogue between the countries that WHO convened, or did WHO convene their experts in multiple countries and use the experts to convene? What were the sort of processes that time limited that you set up? How long did they last for? What other actors did you crowd into that space, or none? Over to you.
Well, thank you for this question. I would like to maybe focus on Malaysia, because this is where I was stationed, and the first cases, as usual, the outbreak was detected between Christmas and New Year 2019. So that's a difficult time to reach anyone. But we brought in first our communications emergency team people, and we briefed the whole UN country team in Malaysia about the outbreak. The most difficult part was actually, in the case of Malaysia, to negotiate that international experts being seen alongside with the Malaysian Ministry of Health in the field, because of the sensitivity of the issue around migration, and also being vaccinating children of migrant families. So this took actually several months, the planning, the negotiations, and the planning with the state government, with the preparations, the micro planning, the communication, building trust, because this is not a COVID-19 campaign with mass vaccination centers. It is combing literally with teams through the remote villages in Borneo, the state of Sabah, which is a very, very big area. And then at the same time, we had, so what we did is we worked through the WHO offices in Indonesia and in Malaysia to coordinate timing, to discuss, and with the global level, actually with the polio teams at global level, and both regional offices in Southeast Asia and the Western Pacific, to determine which vaccines are being used and when the campaigns would be going through the areas, in particular in the border areas. And so that was really just the planning took at least 6 months, if not longer. And then and the start, until everything could start, it was very close to the COVID-19 outbreak. So the second campaigns in Malaysia actually fell, or the last campaign, it fell into the COVID-19 outbreak. So there was really a delay. So it was a very complicated time. And amidst these basically dual outbreaks.
And I want to have one more question to you, and then I want to go back to Thomas and Jennifer for the follow-up questions I flagged earlier. And Eric's part of this panel too. And after I've done that, Eric, I want to come to you, and then in the background, hopefully Selena is harvesting questions from the chat that will take us through for the last 12 minutes of this session. So, I mean, the last question I had for you, Dr. Lowe, was really Mohammed in his presentation talked about multilateral processes and organizations and the importance of regional organizations. Now, you're sitting in the Western Pacific Regional Organization of WHO, a Lao country office, and I know you've been in Vietnam as well as Malaysia, as you said before. And I'm interested in the implications for WHO, how you engage as a convener, but also as an enabler of more regional mechanisms, ASEAN, or the ASEAN Centre for Public Health Emergencies and Emergency Diseases, how you see the interaction between those regional bodies and WHO's role. That's a big question, but so just, you know, at a high level, interested in your perspective of new actors before I come to Thomas, or new mechanisms. Over to you, Dr. Lowe.
Well, thank you. The ASEAN Center for Emergency EOC, not emergency outbreak and responses. Yeah. So that it didn't play a role during the polio outbreak. Interestingly, it was very active during the COVID-19 pandemic. The polio outbreak was not raised as at this committee. There were no special sessions because it involved only a very small number of countries, but it played a big role during the COVID-19 outbreak. So WHO was not part, has not a seat of at the table at this emergency outbreak centers, but all the countries which are part of this Asia EOC actually were part of the regular discussions, actually every 2 weeks with the member states, and in the beginning even every week, to plan the COVID-19 response, to share cases and to share also the availability in the early days of new diagnostics, because WHO provided the first COVID-19 diagnostic through its mechanism. So this information was then shared across the two WHO regions through the ASEAN mechanisms. So it was they convened separately, but it was a similar information which was shared. So I had the privilege to be based in Malaysia. So Malaysia is hosting the ASEAN Emergency Operations Center. There it is. So, but in the case of the polio outbreak, it didn't play a role, but it could be activated. I think the importance of WHO in very sensitive matters is that we are a trusted partner, or we could regain the trust because we advise the country very discreetly, because some of the matters are really super sensitive, right? Particularly when it comes to migration. So your minister, your government would need to know if he calls the WHO representatives or the director in the regional office that there's an outbreak or there is this situation, I need help, that we don't go out and talk to everybody, because political negotiations have to start and public trust has to remain. So, and WHO is in this case very important. The ASEAN AOC can play a similar role, but then there are already other governments involved. So that's maybe the big difference. Thank you for the question. Over.
No, it's good. I could ask forever, but I will balance out the questions to the panel. But thank you for that perspective. I think you hit on a bunch of key features of the convening power of WHO in the region. I want to come back to Thomas now. Thomas, you know, earlier on, both from Dr. Goosby's presentation and Dr. Pate's presentation, we heard about voices. And, you know, of our panel members, those, you have been a voice of civil society and patient advocate for many years. And earlier comments also touched on different power dynamics in some of the boards of the global health institutions. I wonder, from your time, either with the Global Fund Communities Delegation or other, you could reflect on what are some of the better multilateral processes or global forums. When I say better, the ones that are getting better at incorporating and meaningful engagement with civil society, from your experience. Over.
Yeah, thanks, Stephanie. And I think all the health plan and strategy and implementation needs a partnership from the civil society, the community. So it's not just a one-side effort. I think it's like a both side joint effort to make the success of our goal, to achieve our goal more easily. And so like HIV treatment, we need, when we providing medication and laboratory monitoring, we need to consider about the convenience and then acceptability of the community, like privacy and side effects, right? And also other financial burden for the people. I think all these we should. I think Global Fund did quite well. Was they're having a quite a portion is the civil society representative in all different level, global level, and the country level. And I think I was benefit from that. We could have a stage to speak to the decision maker, to the budget maker, about how we expecting the budget could be made, and then even the procurement of the medication. I think one of the typical things was in 2010, WHO already announced we should phase out D4T, and then we should using TDF. And by that time, China there's no plan to change because D4T was so cheap and TDF was so expensive. But I think because of the opportunity, I could sitting in the same meeting room with the government procurement officers and the budget makers together, and then also we can mobilizing the patients to talk to their doctor. We don't want D4T. And eventually, just in about 1 year's time, we changed the guideline. And I think this is not just like we're getting the better medicine, and also overall the HIV treatment is become more successful, and the compliance is increasing, and because we have less side effect compared to the previous regimen. And I think not just about HIV, I think in TB, malaria, in many sectors, it's like I think at this time, the worst lesson learned we can learn is in China about the COVID, right? It's a one side. And then if we don't getting the people's concern and the participation, it's very difficult to have a success health policy implemented. I think that's my comment on that.
So I found my unmute button. I liked your description of the role that the Global Fund has created and supported for civil society from country to headquarter level. And I think I had the great privilege of serving in Australia as an alternate at the Global Fund board over the last 2 years. And the other key feature of that mechanism is that the communities delegation has a vote on all decisions, and it's a majority voting in both blocks organization, where 8 out of 10 of the beneficiaries or co-investor seats have to vote yes, and 8 out of 10 of the donors, and the community's voice is reliable and powerful, and is oft heard, not just to be heard, but to get a vote. Can I come and ask you one more question from your perspective, where you work now on health poverty action in Cambodia? And my question is about the resources available to civil society in order to participate in multilateral forums. How do you do that? Because there's no end of request for input for multilateral processes or votes, either through, you know, WHO processes or Global Fund grant making. You know, you could name a huge spectrum of activity requiring input from civil society. How do you allocate your resources from the job at hand and then support and then feeding into multilateral processes? Over to you.
I think at the moment, in my work, we're using part of them Global Fund money, and some are other funding. We have to getting some different resources, and I think at the moment based on HIV clinic, we try to practicing point of care and also integrated mental health and HIV care together. So when we using some small grant to set up a pilot model, we are going to try to convincing the key player in the HIV program, HIV Global Fund program, to look at that. It's a way we should investment on that. And so I think sometimes we are not, civil society should not just say, become waiting for the job, waiting for the order. I think from our own demand, because we notice that we're always talking about stigma, discrimination, and then what is the outcome of that is mental health problem. So now we just starting it about 6 months time, and we're trying to find out more results to share with the other expertise and other organization. So it's a community initiative. We hope that we can getting more people's attention in this issue.
I just realized the way I asked my question before was so bureaucratic and process about how do you feed into other people's processes. I like that you turned it around and said, we choose what we care about and we will find the key player. And that idea of finding the key player or players is so much of what the lift is in, you know, taking issues from the field to program managers to multilateral agreements or resource allocation. I really like that. I'm going to keep moving and share the question time come to Jennifer now before going to Eric. And Jennifer, I gave you a hint of my question before, but I want you to forecast some of the issues on the horizon that you see either MSF elevating or other actors from how you're seeing major tension points or opportunities. Over to you.
I think there's so many issues that are being elevated, but if we stick really to the very clear health related issues that MSF discusses, the reduction in funding for neglected tropical diseases is certainly something that we're seeing coming post-COVID response that concerns us. NTDs are something that MSF has tried to keep in the forefront of its operations for decades, and we keep going back to and verifying that strategic importance of keeping NTDs at the forefront of our mind. I mean, for instance, the UK government has recently reduced its funding for visceral leishmaniasis, and it was one of the primary funders of the response, and there aren't that money out there. And so we don't want to see ourselves go backward post-COVID when so much of the funding is rightfully, being put into that effort. For us to The other thing that we're seeing, I mean, with the massive amounts of cholera outbreaks over the last 6 months or so, I think 29 countries, the last I heard, really, really important that we have the cholera vaccine available. And, we've had to go down to 1 dose of the 2-dose vaccine. And so we are ringing the bell about that. But almost not more importantly, but more future looking, is this convergence of the shortage of the vaccine, of climate issues, and of migration, which are creating this crisis in many different countries. And so drought, flood, whatever it may be, actually creating a situation where folks are not able to get potable water, and accelerating the spread of the disease, and then people on the move, and then not having the vaccine is a real, we could be at a real point of crisis here. So I think those are 2 main areas, sort of the knock-on effects of COVID, and then climate and people on the move are 2 of the big sort of thematic areas that we're thinking quite a bit about.
How would your strategy to elevate those issues or affect resource allocation differ? So when you say NTD funding versus cholera vaccine access, give us a sense of steps 1, 2, 3 on each of them, broadly speaking.
I don't know if we're that organized. No, I'm kidding. We are. But, we did endorse the Kigali Declaration on Neglected Tropical Diseases, and we've, committed to continuing our own response, particularly with people affected by leishmaniasis, snakebite noma, and sleeping sickness. And so that was sort of step 1 on neglected tropical diseases. So that would be one area. Then the other thing that we would be working on, which I mentioned, the Drugs for Neglected Diseases initiative, is actually being able to develop responses to all of those diseases, whether it be treatment or vaccination, diagnosis, that are more are scalable and more accessible in the places in which we work. And that might be, advocating for drugs that are currently out of development, which are used for other types of diseases in high-income countries that actually could be used for things like leishmaniasis or others, and talking to pharmaceutical companies about how to actually navigate development that works, get the price down, get it accessible, and get a pipeline in to our supply centers. On cholera, one of the sort of strongest, clearest responses that MSF has is to cholera outbreaks. We pragmatically handle it very well. We can mobilize people on the ground. We can get isolation units together. We know how to stem the spread of the disease. But the challenge that we're seeing is the actual acceleration of cholera and other diseases by virtue of the climate impact. And so then where does that leave MSF? Because for some time we said, yes, climate is coming, climate is affecting our patients, but so does war, right? So do all of these other things. So MSF can respond, as it always does, to emergencies. But what we're seeing with the climate impacts is it's so far beyond our scope that really we actually have to advocate and start talking about how we advocate in addition to that pragmatic response on the ground. And that looks so different in every place in which we work. I mean, a cholera outbreak in Haiti does not look the same as a cholera outbreak in Syria. And so we really have to be able to hone those specific messages, but also do what we're doing right now, which is talk about sort of these global influencers on the different disease outbreaks.
I've got so many more questions I want to ask all the panelists, but I'm going to do my job as chair and timekeeper. It's 6 minutes to the hour. And Selena, if you could turn your camera on for a second, because I just wanted to check in with you and also Eric, because it sounded like, Selena, when you finished your questions, you had an additional one for Eric. I just wanted to check in if you had questions unsaid or you wanted me to ask a couple of questions, which I have up my sleeve here.
No, it's quite all right. In fact, there are a couple of questions in the chat, in the Q&A, that are similar to what I wanted to ask Eric. So you can go ahead, Steph. Thank you very much.
No worries.
I can summarize a couple of the questions for you too later.
Okay. All right. Well, actually, Eric, I was interested, and I'm sorry it's taken me so long to come back to you, because when you were giving your introduction, it just struck me that your experience in the US government and how the US government, former experience, puts health at the center of its foreign policy, and really has done since the beginning of, not the center, but as a core foreign policy issue, not as a non-traditional foreign policy issue, or not necessarily out on the sides, but really at the heart. I had sort of two related questions about, one of the questions I get asked and I never have the right answer for is, why is PEPFAR the world's biggest single issue health initiative? Why did it start at the Department of State? And I'm wondering if in your answer, you can pick up some of the themes of from a member state or a nation state perspective of health at the core of the foreign policy agenda. Over to you.
Sure, it's an interesting question. PEPFAR is fundamentally a bilateral relationship from one sovereign nation to another one. That's how the US government relates to this activity and explains it within its own bureaucratic machinery, and justifies it in an allocation decision. So the State Department is an appropriate conduit through which something of this size, which is the largest public health response by a government on the planet. It dwarfs the post-World War II Marshall Plan, corrected for inflation and all. But the scope of it is an extraordinary display of commitment, and has been sustained for almost 20 years now. The themes that I heard in all of the discussion of the panel speak to this point to me. Wonderful that there are individuals and organizations that are able and willing to engage in responding to unmet need in places that are distant from their locations. And I dedicated much of my life to that, as most of you have. But as I get older, plus and negative of that approach, and the negative side is the unintentional diminution of accountability that you create by having an external bilateral country-to-country relationship, a multilateral relationship to a country, or a foundation as a funding line that covers the needs of the population in a central critical problem that will be sustained, not episodic, will continue. And the resource, both intellectual and money, systems, bureaucracy, procurement, distribution, et cetera, that comes in, which is urgently needed in the short term, in the emergent moment, does not transition, sometimes ever, into a hand back of the baton to local resources, local decision-making, and local control, and thereby loses the accountability that organically comes out of those who depend and need the services in a dialogue with those who are making allocation decisions. And I think that we as a global community need to really understand how those engagements impact in the short and long term, and how we can, by the way we set up governance, doing things like understanding the importance of civil society, and looking at funding lines that support their involvement in both local and multilateral international discourse about the resources needed for their country and their problems. But that we each and every time connect the dots to the organization and entity, the government, that is charged by the population to be responsible for their health, and do things that amplify and support the government in playing that role, not diminish it. And that's kind of the piece that I really see more and more as we look for sustainable responses, as we look what COVID did, understand that we need to align our governance with mechanisms that are institutionalized, that allow for inclusion, issues of equity to be brought in, but that are laser focused on enhancing and preserving the lines of accountability.
Do you have examples of where you think that has worked? Because like you can't disagree, right? Because we've all been in places where there is a dizzying array of actors, and to your point, the vast majority with good intention of service delivery and support in the short term, but that dilution effect of accountability in the medium term. But sometimes I look at the sector that we're in and I don't see any change in the proliferation of external effort, or comments noted earlier about change in funding from various actors. And you talked about PEPFAR as a bilateral vehicle and kind of a process that had evolved to make it more responsive and accountable. But where we are in a arguably busier global health world every year than we were 5 years ago or 10 years ago, where has that line of accountability, to your mind, worked in a multi-stakeholder process?
I think, Stephanie, it very rarely works. I think most of our multilateral, bilateral foundation efforts dilute it. They don't strengthen it. And the countries not only drop their funding for all of these activities, but never come back to it as a funding line that is reinvigorated and that they hold themselves accountable to absorb what that bilateral or multilateral program or foundation program has created. You never see that transition back to a handoff of oversight, management, monitoring, and evaluation back to the country, using their systems of care, understanding and incorporating their formularies and their procurement distribution system, and not coming in with guidelines that speak to other countries' standards of care and try to implement them in theirs. Not that we shouldn't always push for what the science says is the best. That's what the discussion is about. But to snatch the responsibility of what they decide to give as the standard of care out of the voice of the patients who receive it and need it, and keep it as a donor decision or a foundation decision, is not a sustainable position. And we don't kind of talk to ourselves about what we're creating. We just go ahead and do it. And our transition out of program is abrupt and dangerous, often, more often than not. So, the number of times I've seen a domino fall with a rapid exit of the most well-meaning, most impactful and effective services because of other things creating that urgent removal, I can't count. It's rare to see it well done. It really is. And PEPFAR is by no means a good actor in this. PEPFAR came into countries and set up parallel systems of care, didn't use the clinics and hospitals of the country in which they were now introducing themselves as a resource, and evolved into planning with together and implementing together. That was an afterthought. That wasn't how PEPFAR came in. And it's still a struggle to implement that, because of the 20-year history of doing it a different way. Also, the complacency, if I could use that term, in the kind of consciousness of the institutions and country to not really behave as if this is their responsibility, but allowing a numbing to come in when a donor has spent 20 years covering this need. And we are smart enough to do this better.
I feel like if Dr. Pate was here too and not on video, he would probably intervene at this point.
He would be screaming up and down about it. Yes.
Yes, on plan, on budget, and on system. And Selena, I can see you have turned your camera on, and we're here at 5 past the hour. We didn't get to questions in the chat, but I think I'm going to forgive us for that moment and ask our panelists to turn their cameras on so that we can thank them all at the same time for what I wish we had more hours to do, and one that is tricky to convene by virtue of the breadth of experience but really useful perspectives. We've talked about negotiations, we've talked about governance mechanisms, alliances, minilateral, working behind the scenes, working in broad daylight and as an advocate. And I think what the panel demonstrated today with such a breadth was all the different forms that a deliberate attempt to elevate and act on our collective interests in health can take many forms, and what we need these multiple actors, not only acting and doing what they do best, but to Eric's sort of closing point and having our eyes wide open to what we're all doing together. Thanks, Selena, for the opportunity to convene. There are some yellow and other hands floating up on the side. I'll give my physical round of applause to the panel and thank you for your time today. And I will hand back to Selena as our MC. Over to you, Selena.
Thank you so much, Steph, for that absolutely brilliant moderation and really rich discussion. So I've just popped into the chat that we're not forgetting all of your questions. They were really excellent. And I've made a commitment that we're going to answer your questions. I will communicate with the panel in terms of how to do that, and we'll post it on our website shortly. But in the meantime, we ask that you take a break of about 8 minutes and come back at 3:15 Australian Eastern Daylight Saving Time. So that's in about 8 minutes to have a quick break. But please don't leave. Come back. We've got some excellent speakers lined up after the break. And finally, some of the questions that were put in can actually be answered in our final panel with Anders Nordstrom on future reflections. Thank you so much to everyone, and see you in about 8 minutes. So welcome back to the Alliance Congress 2022. We just finished a really brilliant panel moderated by Dr. Stephanie Williams. And our next speaker is Renzo Guinto, who is the Associate Professor of Practice of Global Public Health and the inaugural Director of the Planetary and Global Health Program at St. Luke's Medical Center College of Medicine in the Philippines. Concurrently, he's also the Chief Planetary Health Scientist and co-founder of the Sunway Center for Planetary Health in KL, Malaysia. These are only some of his titles and contributions. And in fact, in 2 words, I can describe the Renzo phenomenon as a refreshing voice. Renzo has taken the field of planetary health and advanced it in action. He is a member of the National Panel of Technical Experts of the Climate Change Commission of the Philippines and convener of the Planetary Health Philippines, an Obama Asia Pacific leader and Aspen Institute New Voices Fellow. He served as consultant for various organizations, including the UN and Lancet Medical Journals, on planetary health. He's lectured, he's published, he's spoken, and even directed film. In 2020, he was included by Tatler magazine in its Generation T list, I'm not sure what that is, of 400 leaders of tomorrow who are shaping Asia's future. And there is no doubt in my mind that he will continue to shape the future of global and planetary health with his dedication, creativity, and insistence on listening to others as part of his great contribution for many years to come. Renzo, over to you, and thank you very much for joining us for this second session.
Thank you very much, Selena. Can you hear me clearly?
Yes,
wonderful.
we can.
Excellent. Thank you so much for the generous introduction. But of course, thank you very much too for this opportunity to address the Australian Global Health Alliance. I'm joining you from Manila. And so let me just share my screen, and I hope you can see my slides now. And I've been actually listening for the past several minutes to the previous conversation, and I think my 10-minute presentation will really reinforce some of the messages that have already been raised by our esteemed speakers in the earlier panel. I think that the future of global health diplomacy must decolonize, decarbonize, and democratize. And I will be elaborating on these aspects in the coming slides. And first, I just want to congratulate the Alliance because you just organized a Congress that has no Manel, Wanel, and Hikanel. And you probably are wondering, what do these terms mean? Manel pertains to all male panels, Wanel, all white panels, and Hikanel's all high income country panels. In fact, the photo that you're seeing on the screen is a Manel, Wanel, and Hikanel all combined. And in this day and age of Zoom even, we should not be seeing all these kinds of panels. These should be made obsolete. And we should be including more voices and faces and peoples from different places as we try to reshape global health moving forward. So I congratulate you again, Selena. And of course, I am feeling deeply privileged as a brown young Asian to be joining this conference. I remember a while ago, Professor Pate mentioned that there are still asymmetries in networks and connections. And I just happen to be privileged to know Selena Law to be part of this important conversation. I hope there will be more young people to be part of these important networks and communities. But the picture that I showed to you a while ago is just a symptom and one aspect of the inherent coloniality of global health, our field and our sector. And as already I think mentioned or alluded to a while ago, and as you have witnessed over the past 2 years, most especially during this pandemic, there have been a lot of discussions and discourses around this idea of decolonizing global health. You're seeing here many of the headlines that have been published over the past 2 years, raising these difficult questions and also proposing ideas on how we can reach a decolonized global health future. I'll not go into the details of these headlines. But I think what we need to remember is that in our pursuit to decolonizing global health, we must go beyond the cosmetic. It's easy to put a young brown Asian in the program of a conference, and you can tick the box and say, we've already decolonized the global health conversation. Or add more African sounding names in the bylines of a research article and safely say that we've already incorporated voices into, for instance, global health scholarship, education, and practice. We need to really look into the underlying structures and the mental models that underpin these global health colonial patterns, behaviors, practices that we are seeing in our field and in our sector. And as already mentioned also by Professor Pate early today, decolonizing global health and global health diplomacy is about tackling the asymmetries of power and privilege. All these problems that we've been talking about, raising for the past several years, the defects of the global health system, racism, white supremacy and saviorism, patriarchy and sexism, lack of diversity, equity, and inclusion. All of these are parts of the same elephant, the elephant that is characterized again by these inequalities in the distribution of power and privilege in the global health system. For instance, these inequalities are very much reflected in how global health leadership is distributed across organizations, but across individuals as well. I'm pretty sure you're very familiar with the annual reports of Global Health 50/50. And as you can see in this map, the majority of global health leadership still is based and lies in North America and Europe, while global health is designed and created with the idea of serving the underserved, the places where global health problems are still very much being felt in Asia, Africa, and Latin America, among others. And it's not also about just the old powers that continue to perpetuate their dominance in the field of global health. We should also be taking a closer look at what I describe here as the quote-unquote neo-colonizers of global health. Because it's not only the old empires that are dominating global health. We also have new non-state actors, big foundations, transnational companies, multilateral agencies, even schools of public health and global health institutes exerting their disproportionate influence in global health knowledge production, decision-making, policy-making, funding, and all other aspects of the global health field. And when we talk about decolonizing global health, as I already mentioned a while ago, it cannot just be a tick box exercise. We need to be measuring the impact of our decolonial approaches and activities. And I believe that the way to do that is to measure equity both in the operations of global health, how we hire, how we educate, how we train, how we fund, how we govern, and also in the outcomes of global health. And of course, the persistent inequalities, if not apartheid, that we're facing when it comes to COVID-19 vaccine as we speak today is one clear measure of the lack of decolonization, perhaps, or the creeping coloniality of the global health field, the global health sector of global health diplomacy. This must change. So I already talked about the first letter D, which is decolonize. We also need to acknowledge that the health of the global population is now being shaped by many factors, many forces that are way beyond the unseen coronavirus that probably we're still very much concerned about. Of course, we're still afraid of future waves of COVID, but we should also be equally, if not more afraid, not just of future waves, but also future tsunamis of climate change and biodiversity collapse and all their myriad health consequences if we do not get our acts together sooner rather than later, as depicted in this caricature. And in my home country, the Philippines, this has been very much felt over the past 2 years. We've seen the confluence between two crises. On one hand, the COVID crisis, on the other hand, the climate crisis. And imagine you're a poor Filipino confronted with a dilemma On one hand, do I stay in the house to protect myself from SARS-CoV-2 only for the roof of my house to be blown away by the strong wind? On the other hand, do I move to these cramped evacuation centers free from climate-related extreme weather events like typhoons and flooding? But as you can see in this photo, there's no social distancing to begin with in these temporary settlements. Therefore, there's a very high chance that you will be getting COVID-19. But unfortunately, despite the recognition that health is going to be impacted by climate change, health is far from being at the heart, at the center of climate action. Every year when the annual COP, such as the recently concluded COP27 in Egypt happens, health still remains to be a side event, a pavilion in the climate negotiations. When can we be at the heart of the negotiations itself? And we are only mentioned once in the Paris Agreement, and even in the recently agreed upon implementation plan in COP27. How can we be a dominant part of all these climate agreements? Health-focused climate adaptation and mitigation funding, almost negligible. And also health is not even included in the calculation of loss and damage. Of course, that is, we're very glad. It took us a very long time to have the loss and damage provision in the COP outcome documents, but health is far from being included in these in the calculations of such loss and damage. So we still have a long way to go in making sure that health is part and is at the center, front and center of climate action and climate negotiations. But climate change isn't in health either, because the global health community, including the global health diplomatic community, is operating as if the global climate system is doing okay. Climate and health is just one topic. It's just one resolution, instead of being at the center, the main frame of all the negotiations that we're having in global health, whether it's the pandemic treaty or future resolutions focusing on specific disease areas. And so we need to do a better job in putting climate change at the heart of the global health sector and the global health diplomacy's work moving forward. And so that is why there's this new concept called planetary health that was proposed, that was born. It was first introduced in Lancet Rockefeller Commission report in 2015. And basically, as a physician, the way I see planetary health is that in the 21st century, we now need to be treating and taking good care, not just of one patient, the human patient, but two patients, not just the people, but also the planet. And I think planetary humility is an invitation for the global health sector, for the global health diplomatic community to planetary humility. It asks us to shift away from this egological approach. Oh, we human beings are at the top of the pyramid of nature. We can consume, extract, mine, pollute, as if the planet has limits. And instead, we need to shift towards a truly ecological approach, where we human beings are living in greater interdependence, in solidarity with all creatures, great and small, and all the other components of our planet Earth are one and only home. And so I already mentioned that we need to decolonize, we need to decarbonize, but we also need to democratize. And in the earlier panel, we've already heard several times about the need to include different voices that are always not represented around the decision-making and in the diplomacy negotiating tables. And we need to have more young voices. Global health must be younger, not just in terms of education and training, but also in the way we operate, in the way we govern, in the way we make decisions, in the way we discuss about these pressing issues. We need to incorporate indigenous voices, not just from Australia and the Pacific, but also from the Philippines and Africa and many other parts of the world. We need to take advantage of digital platforms to really capture the pulse of everyday people, what they want to be happening in the global health field and the global health sector. What should be the priorities that should be based on the needs and desires of the peoples of the world? And we need to make sure that civil society are meaningfully engaged, not just tokenistically engaged in the global health discourse, in the assemblies, in the meetings. And in particular, I just want to highlight meaningful youth engagement. I laud the World Health Organization for planning to organize the first global model WHO this upcoming February 2023. But I think we need to go beyond that. We need to go beyond these simulations and go towards or move towards true solidarity with the young people of the world who are already affected by many of these global health challenges and who will also be the leaders and decision makers sooner rather than later. And so I think to conclude my remarks, global health and global health diplomacy must also embrace this idea of intergenerational responsibility. We only usually talk about the well-being and the needs of the people who are living today. We need to be thinking along the lines of 100 years. What are the young people and the future generations who are yet to be born will be thinking about, will be requiring in order for them to live healthy and prosperous lives. I think that we are being called to become good ancestors, not selfish ancestors. And what we want is that in 2122, which is 100 years from now, the children of 2122 will read the history books, will look back to the past, and they will say that the COVID and climate generation of 2022, which is all of us in this Congress, have been good ancestors to them because we made the right decisions, not just for our own health, but also for their health and well-being as well. Are we ready to decolonize, decarbonize, and democratize global health diplomacy? That is the question. Thank you very much, and I look forward to our conversation.
Wow, thank you so much, Renzo. That was fantastic and a great opening to this session. I ask the audience that you hold your questions for Renzo for our short panel, but please feel free to start dropping in the box right this minute. We're now going to hear from specific important voices in global health, and I'd like to introduce the panel together first, and then we'll hear from each of them. First, Professor Kath Chamberlain, who's the head of Indigenous Health Equity at the Melbourne School of Population and Global Health. You can read her bio on the website. She's going to speak on a topic titled, "It's Time for a Cultural Renaissance. Are we emerging from an Australian Dark Ages?" Then we also have Dr. Farna Sabat joining us from Jordan, speaking on pregnant adolescents in low middle income countries and their care, the importance of local framing of complex health issues. Dr. Sabat is a general practitioner with extensive experience in global health practice and policy. She's also a researcher at the Murdoch Children's Research Institute and has worked for government, NGOs and academia across Africa, Middle East, Southeast Asia and the Pacific. And very gratefully, we have Kim Allen, who's just joined us from Port Moresby in Papua New Guinea. He serves as the current chairperson of the Commonwealth Youth Council and is also a member of the Pacific Island Forum Secretary General's Young Climate Leaders Alliance. He's going to share with us on the voice and integration of youth in governance globally and regionally. So I will just start by handing the Zoom chair over to you, Kath.
Great. Thanks, Selena, and thanks very much for the opportunity to join this really exciting event and discussion today on global health diplomacy, hearing from young, emerging and missing voices, and Renzo for that really great introductory presentation, which was incredibly inspiring and, really resonated with a lot of the discussions that we have here in Australia as well. I'd like to start, as we always do, by acknowledging that I'm calling in today from the lands of the Wurundjeri people of the Kulin Nations here in Naarm or Melbourne, and pay my sincere respects to their elders, past, present and emerging, and extend that to all other Aboriginal and Torres Strait Islander, Indigenous people, and other people here joining us today. So I'm a Palawa Traway woman, descendant of the Traway people from Tasmania, a midwife and Professor of Indigenous Health at the Melbourne School of Population and Global Health, as Selena outlined. And I just wanted to talk to you a little bit briefly today that, this is a really watershed time for us in Australia as Aboriginal and Torres Strait Islander people at the moment, and consequently for our nation. Our story here in Australia is ancient, at least 60,000 years old, and very diverse, with over 250 distinct Aboriginal and Torres Strait Islander countries within what is now called Australia, each with their own laws and customs. And there's a lot of evidence that at the time of colonisation, around 1788, Aboriginal and Torres Strait Islander people were healthier than people in Europe at that time, and certainly healthier than the people that arrived here by boat. Initially here, being sent here often by punishment, and subsequently since then seeking safety, refuge, and a better life from where they've come from. And it's really important to acknowledge that at this time, around 1788, we know this state of well-being, it wasn't achieved by accident. It was due to all these laws and systems that were in place, and they were really centred around fostering well-being, and the centre of that, our understandings of well-being, were around the importance of connectedness, which we know to be really critical. Connectedness to ourselves, knowing who we are as an individual, connectedness to our families, to our kin, to our communities, connectedness to country and the land that we're with, which really resonates with what Renzo was just talking about, having that important cultural connectedness and having culture at the centre of our life, and connections to our spirit and those really important ancestors that we were just talking about then as well. But over the last 200 years, we saw really violent and active suppression and dismantling of these laws and systems through that have been associated with colonisation. And the front line of these attacks was directly on disrupting those connections. This included the forced removal of children from families, laws put in place to ensure that some people, the people living in the reservations, didn't communicate with the people not living in the reservations, sanctions to separate families, and lots of other laws to create dispossession from land and removing people from their traditional lands. And this included the use of lots of coercive threats and powers of the state, which often was the threat of having your children removed. And this could be for things like here in Victoria, if people spoke their own language in Victoria or practiced cultural practices, then they were threatened with having their children taken away. So the other thing that's happened at this time with all this violence is that we weren't allowed to tell our own stories. So people have been told stories about us, written by non-Indigenous people, through this blurred lens of racial prejudice and assumptions of knowledge inferiority. And this legitimacy of these stories and the knowledges were then reinforced, when they're integrated into all of our health programs, our policies, and our education systems with our healthcare workers and things. And, this is really particularly an issue for us working in research, the area where I am, where we're really trying to change that narrative now. But it's an important time for us now because there's a lot more Aboriginal and Torres Strait Islander people now being able to tell our own stories. If anyone hasn't read the Uluru Statement from the Heart, which is critical for us, I urge you to do that. It's one of the documents that I hope one day my grandchildren will be reciting. And it's a real expression of our aspirations to be heard as the voice. It includes a call for establishment of a First Nations voice enshrined in the Constitution, which is our national birth certificate. At the moment says that this place had no people living on it when the Europeans arrived and took over it. And so in about a year's time, Australians will be asked to vote and decide whether or not to recognise Aboriginal and Torres Strait Islander people in the Constitution, and whether or not to allow us to have a voice to Parliament about issues that affect us and our health. So I'm really excited about these opportunities. It's quite a it feels a little bit like we're emerging from a time of, you know, an enlightenment akin to the European Renaissance, as if it all is successful, of course, which we really desperately hope that it is. You know, really emerging after this time when, you know, where all of our knowledges have been suppressed, and like in the Dark Ages when the books were burnt and people's voices and spirits suppressed. And now we're able to, you know, able to bring all this to life, and all those things that Renzo was talking about. Such an important time to understand that 60,000 years of knowledge and history. You know, lots of people have died here where I come from in Tasmania, in the place around Nipaluna, or what people call Hobart. Every single person in that community died. There's not one single surviving descendant to carry on the spirit of those ancestors. So there's some stuff that has been voices that can't be heard, but there's still a lot of thriving communities in Australia that we really need to revitalise and allow to be heard now. So one of the things I wanted to say is that, you know, I think it's really natural to feel nervous and fearful about things that are new and different in Australia, and this is probably unusual for people coming outside Australia, but this isn't something that people should be afraid of. It's essential to have this kind of enlightenment and truth-telling. It's a chance for Australia to grow as a nation and to be enriched with these ancient knowledges centred around the values of connectedness and all those things that Renzo's just talked about now. It really is a gift and an opportunity that, you know, I really hope that we can all embrace. So that's all for me, and I'll pass over to the next speaker and look forward to having a discussion on the panel.
Thank you so much, Kath, for that introduction. I will hand over now to Farnaz, who's going to talk about pregnant adolescents in low-middle income countries and their care. Thank you so much.
All right. Thanks, Selena, and thanks, Catherine. Look, I'm very happy to be here to talk about an issue that I'm obviously passionate about. I just wanted to also thank my supervisors. This is part of my PhD, especially Professor George Patton, who has been wonderful. So as part of what I'm drawing on the panel and talking about missing voices and actions not done, accountability, all of the things we've discussed in this Global Health Diplomacy Forum, is looking at a review of interventions for pregnant girls in low and middle income countries. This was a very extensive review we conducted. There was no language restriction, no restriction on the type of evidence or the quality of the evidence. And we also looked at sub-analyses across general maternal health interventions. And in essence, we found almost nothing globally that supports a pregnant girl from her pregnancy to delivery to postnatal, to 6 weeks postnatally. Not one high quality study that provides evidence to support them in a low middle income setting. Now, given 95% of adolescents who are pregnant live in low middle income countries, and that's amounting to about 21 million girls a year, and 12 million of them give birth. This is not, this is a substantial group of people who are missing from the policy sphere. Now, there's a story when you do a review, normally it's to find something to give a suggestion to, and this really found a story, a missing story, and there is something to be told when you don't find something. Because there are thousands upon thousands of articles showing poor outcomes in pregnant girls in low middle income countries. But that story, that literature is being used to bolster a prevention approach. So I want to shift now a bit to something more in line with the topic of the forum today, and that is issues around power and framing. So when you have an unchecked dominant framing that stems really from the cultural north, it ultimately leads to the neglect of many. So let's look at pregnant girls. Who are they? They're young, they're girls, they're often poor, they often come from marginalized and isolated communities, rural settings, and from ethnic or racial groups that are often discriminated against. Yet they're thrust into adult responsibilities, but have no democratic voice. They're underage, and they're really a group that whose actions, even clinically, are decided by others for them. So I started to look at, well, what is the dominant framework? Because I essentially looked at all the literature around this issue in the world, you could start seeing that there was one story being told about pregnant girls that was coming in literature from all around the globe, whether it was Iran, India, South Africa, tended to have one story. And that was a dominant story from the cultural north, that what is the desirable path for a girl to pursue is economic and educational opportunity, and motherhood squashes that. So you really had a story where everything was focused on preventing the girl from falling pregnant. And that is needed and necessary, but having one narrative in a world where we have a diversity of values and a diversity, especially something that's complex like adolescent pregnancy, encompasses gender, violence, marriage, fertility, there's something missing when there's only one story being told. And when you look at it, it's a strong neoliberal, a narrative around the neoliberal individual, someone who has autonomy, can make their choices. And this narrative creates less sympathy for girls who do fall pregnant. We have studies on this from the US. The stronger you are in the view that an individual should have autonomy and responsibility for their decisions, the less sympathy you have for girls who fall pregnant. So a lot of the discussion today is, okay, so this is how, this is the structure we have. Do we have an example of something different? And there was an example of something different. And this is what I want to share today. And that was really coming from Latin America. Because this review did not exclude poor quality evidence and evidence that wasn't in English, there was another story that you don't hear in the English scientific literature, an alternative narrative coming from Latin America towards pregnant girls, and a narrative that purposely pushed back against the dominant narrative. They didn't frame pregnant girls as victims, as uneducated, as those that needed support in order to become autonomous, but rather they saw their needs as legitimate. They framed them in a way, had overarching researcher confidence in their needs and their ability to voice their needs. So this is how they framed them. They framed research with such girls or interventions with such girls as a privileged space, as the potential in that space to construct collective and individual significance about pregnancy and teenage motherhood. And within that narrative that was developed locally, regionally, in their own local university settings, their local funding, it was very difficult to have a patronizing and disrespectful attitude towards girls. So I wanted to show this example of, it's not, because there's many interventions that included the voices of pregnant girls, but still in the dominant narrative. So asking girls how to get empowered, how to make choices, which is important, but there is something different that you gain when you allow the narrative to be developed locally, and it needs local and regional scholarship to do that. And when you look back at Latin American scholarship, they question that narrative coming from the North and question imprecise biomedical arguments supporting that narrative. And ultimately, when you allow that to happen, you get much better responses for those on the ground and for pregnant girls on the ground. So I look forward to this discussion. I know I've crossed a lot of issues here, but I really look forward to discussing more on the panel. Thank you.
Thank you so much, Farnaz, for your work and for your intervention today. So finally, I'd like to hand over to Kim Allen on voice and integration of youth in his work in governance globally and regionally. Kim, if you can share some of your wisdom and tips for us, we will be most grateful. Over to you.
Thank you, Dr. Selena. Thank you, fellow panelists, for sharing your insights, and of course, the audience. My name is Alan, and I'm the chairperson. Last week, I was grateful for the opportunity to be in Canberra. We were part of a Pacific Australia youth delegation to meet with parliamentarians and in Australia. Some of the insights that I will be sharing is from those dialogues and from our research conducted across the Pacific region, especially within young people. Now, before I go into my sharing insights, when I was growing up, I grew up in the village in a remote island in Papua New Guinea without access to health, education, communication. And I observed first-hand experiences that challenged the inequality gaps between even remote and the urban. I never knew of what's life like in the urban areas until I went for further education in high school, and I realized, the life that I live in a remote Papua New Guinea is totally different from the urban towns and cities in PNG. Early this year, I received a call from my home that they were transporting one of my fellow youth from home to the nearest urban center. And in the middle, because of weather and transport issues, the boat sank. Unfortunately, one of the young people who broke his leg due accident couldn't swim and he drowned because of that unfortunate event. The rescuers went and rescued them. This is the first time challenges, especially for remote communities, and I think it's across the Pacific Islands. Reflecting on youth involvement in governance. Firstly, to us, like, what is governance? Most when young people are sharing this perspective of governance, they think towards politics or government systems, but government in context. For me as a young individual, and by the way, I would like to also appreciate this opportunity to share these insights on behalf of young people, and of course acknowledge the youth individuals in the Pacific, in Australia and the Pacific region, who are taking lead in their respective roles, addressing the issues of climate change, all the issues of health, maternal rates and so forth. So young people are taking action at the forefront. And reflecting on the governance, what kind of structures do we have at the community level, at the provincial, national, or even affecting the global structures, which particularly focusing on health of this forum. And last week in Australia, I was speaking with politicians and other faith-based organizations and networks. There were five discussions we had with politicians. We had the privilege to speak with all the members of the parliament in Australia. And what young people shared are two principles. Number one is self-determination, and second is inclusion. Under self-determination, young people raise the question how much they can make their own decisions, but in order to make those decisions, to be aware of who they are and the issues that are around them and what potential to tap into, either personally or the systems that support individuals to tap into the potential to realize their full capacity to live a life in fullness, either health, education, employment, and so forth. Inclusion evolves around that there is inequality gaps, and we need to call for inclusion in every aspect of policy and its implementation. These are general conversations within the youth space. For the priorities within the youth in the Pacific, number one, climate change. I have to say, of course, recently with the COP27, young people in the Pacific, they're taking lead in addressing the impacts of climate change. You see young people leading mangrove planting, they're addressing water and sanitation through water project programs, they're raising awareness. All these are led, and I have to say, I have seen or even spoken to youth across the region who have done so much great work in their communities. The third priority is addressing water and sanitation. Of course, water is an issue in the Pacific that we for surely know, given we're in the ocean continent. It is an issue. Reflecting on those challenges and those priorities raised by the youth leaders, this gives us some of the recommendations, three recommendations I would like to share. Number one, to get youth engaged in governance, good governance at every level, either community, subnational, or national, or even global. First is the space and the environment, and information access to workable mediums, either information access to malaria, sexual health, reproduction. These are necessary for young people. And right now in the Pacific or even abroad, there is a digital divide, information gap between the young people and information to those particular teams that they can receive those information to make the right choices for their lives. And of course, the dedicated channels of communication, either it's social media, if it's media, or the traditional form of communication. In the Pacific, it's all verbal communication. Two is the pathways through mentorship. How much do we know that if a young person from an early childhood comes to a primary level of education, either health or any sector at all, knows what to do in the next 10 to 15 years old ahead. So those pathways are necessary, and this has to be supported through mentorship program In education, of course, there is a huge inequality gaps in education. You see high employment rates in my own country, in Papua New Guinea, and with formal and non-formal and informal education do address some of these challenges. And of course, support the sphere of influence. And these are youth groups or faith-based organizations, either in community, subnational. There are existing youth networks that needs that kind of support so that they can be channeling those information to the youth individuals in the communities. The third one, and this is to work with existing youth-led networks organizations. There are tremendous organizations on the ground who are doing great work in addressing some of these challenges. And to understand, to work in partnership, trust is an issue. How much, most development partners, international organizations, come with their own objectives. Of course, we respect that objectives, priorities, and so forth. But what is the priority of the government? What is the priority in the local context? That is something that is always a debate in every development space. And we as young people, look, these are the real life. We are living the real situations here on the ground. Why not we focus on those priorities so that you have an impact, real impact on the ground? And of course, respecting community structures and local-led solutions. It's a way for having a community participation, young people at the community level. And having young people in their own efforts, to support them in their own efforts to create change in their communities, of course, to drive this policy change because they are the forefront. So in conclusion, we are facing so many challenges in PNG, in the Pacific, and of course at the global level. While with high infant mortality rates, violence, high unemployment, climate change, unplanned pregnancies, and so forth, not to mention mental health and inequality in education. But in the midst of all these challenges, we all can agree that the issue, when not addressed or minimized, lead to creating another problem, resulting in social issues. This is the main thing I would like to highlight here, and affecting our traditional structures in communities, and that relates to governance. So if we speak of governance, what governance are we having in traditional or in our communities, in our society? So in the midst of all these challenges, of course, there are positive stories that we like to share, what young people are doing on the ground. And of course, it comes back to partnership, to work together to address these challenges. So only when we work with each other as members of the society to support one another, including young people and vulnerable groups, I think we do have a great potential to eradicate these challenges that we are grappling with. Thank you so much for hearing.
Thank you so much, Kim. Thank you to all our panelists and to Renzo. Before we move on to the final session, I really do, there have been quite a number of good questions, but there is one very popular one that I'm going to pose for Renzo to take 2 minutes off, and maybe Kim can add something else. It's Richard Osborne's question: how can we support the current leaders who may well be doing great work proactively give up their control and power to enable and make room for new generations youth to get accelerated experience? Excellent question. Renzo, I'm going to ask you to take that and try to compress your answer. Thank you.
Thank you, Selena. And I think actually Kim gave already some of the answers to that question about creating spaces and including young voices. And I think there has to be a high degree of intentionality from our leaders to really meaningfully engage young people and not in a tokenistic fashion. And I think youth engagement and incorporation into global health, diplomacy in particular, but global health in general, must happen in at all levels. It's not just at the global level, even at the national level. Global health diplomacy is already happening. So ministries of health and other partners at the country level should be actively involving young people in their different processes, and in fact beyond consultation. Because I think the thing that first things come to mind when we talk about youth engagement is, let's organize a consultation comprised of 20 young people, and let's add that as an input to the process. when in fact young people can actually be part of the entire policy co-creation process. And it also generates a sense of ownership among young people to be part of these processes. So those are just some of my thoughts. Certainly a challenging one. And I'm pretty sure there are many other ways by which we can also push and encourage our leaders and the institutions that they belong to meaningfully engage young people in global health diplomacy.
I think we need a whole new Congress on this topic alone. None of you mentioned resourcing, but I know from earlier discussions with Kim that although he chairs a number of really important governance processes, the funding available to meet these challenges is very little. So I think we need to do more work in that regard too, and actually finance the input of young people in dialogue too. So really, thank you to this incredible panel of speakers, Renzo, Kath, Kim, and Farnaz. Please join me on the emoji or with hands or chat in thanking them warmly. And finally, I'm so delighted to introduce our final session on future reflections and horizons in global health diplomacy. I have the honour to introduce our next two speakers in conversation. Very quickly, Anders Nordstrom, thank you so much for calling in early from Stockholm, who's the Ambassador for Global Health at the Sweden Ministry for Foreign Affairs in Stockholm. He has held senior positions nationally and internationally at WHO and also at Swedish International Development Cooperation Agency. He is a huge friend of global health and appears on many different initiatives and important dialogues globally. He shares the stage with Hayley Jones, who's the director of the McCabe Centre for Law and Cancer in Melbourne, also the WHO Collaborating Centre for Law and Non-Communicable Diseases. So if either of you have questions for either Anders or Hayley, please pop it in the chat and we'll endeavour to get to them promptly during this final session. And we may see a final sighting of Eric before he leaves us in San Francisco too. At the end of this session, I will hand over to our Deputy Chair, Jane Fisher, to do the closing remarks. Over to you, Hayley and Renzo.
Thank you so much, Selena, for the opportunity to participate today. I'm really honoured to share the stage with Ambassador Anders Nordstrom, who's joining us from very early in the morning, I understand. So we're very grateful for your time today. Before we start, I would like to pay my respects to the traditional custodians of the land that I'm speaking to you from today, the Bunurong people of the Kulin Nation, and pay my respects to their elders past and present, and to emerging leaders and any Aboriginal and Torres Strait Islander people and First Nations people who might be joining us today. So this session is all about looking to the future, and we've had some really fantastic provocations and discussion in the previous sessions that have really got my mind thinking. But we now have one of the preeminent global experts on global health diplomacy here with us, and I'm really interested to hear from Ambassador Nordstrom about looking to the future. What do you think are the two main global health challenges that we can see on the horizon, and what role do you see global health diplomacy playing in responding to these challenges?
No, thank you, Hayley, and I'm delighted to be with you from another part of the world, from Stockholm in Sweden. When it comes to what's on the horizon, I think one needs to think about whether we think about the health horizon or the political horizon. I had a couple of slides. Let's see whether someone can share those with us. Coming, yes. There is no question that on the horizon right now, across the world, has been this virus. I'm going to share 4 round symbols here. This has been both on the health horizon, but also on the political horizon. No question about that. We don't need to say anything more about that. But the question is, what is on the future? Is that still going to be on our agenda and on everybody's desks and political minds? Next slide, please. Or is it so that we're also going to recognize what we have learned now during this pandemic is that it's not enough to contain the virus and ensuring that we are basically immunizing the whole world, but it's also an issue about everybody's equal right to access to good quality health service, regardless of ability to pay, what we call universal health coverage. This was the top high-level meeting in New York 2018, where we had a political agreement on that. The question is whether that's still on the agenda and on our horizon. Next slide. Or is it so that what is now in the future actually what is in what we call the Agenda 2030 and the SDG 3, which is actually more and more ambitious than just containing a virus or just ensuring that we have access to service? This goal says that we should actually ensure that people cannot just survive, but remain and stay healthy and enjoy well-being. And staying healthy requires something much more from us than just providing universal health coverage and services. That is important, but that is not going to be enough. Here, we will need also actions happening in the climate area, in the environment area, in the food area, in the transport energy area. So much more than possibly that we have been focusing on this far. So my hope is that we will focus much more on going beyond the health sector, because that is also what's going to have an impact on people's health. Next slide, and last one. And even more hope, and delighted to have seen Renzo here, that is to think about not just human health, but also planetary health. I hope that this will be higher up on the agenda. And I hope that this will be higher up on the agenda, not just that this is so important politically, that we get health more into the climate agenda and the other way around, but just looking at the epidemiology. Because if we go back and look at what we had in terms of global health, looking back now 25 years ago, the MDGs, we had 3. We had 20 million people dying from those 3, or relating to child mortality, maternal mortality, and the 3 diseases. We're today down to 8. Big progress. I wouldn't say success, but progress. If we look on the opposite, then what we see now, the escalation of what we call non-communicable diseases. When I began to speak about that, we had 12 million people dying prematurely, 15, 16. Now, just last week, I saw the latest figures, 17 million people dying prematurely that should not die from cancers, coronary heart diseases, strokes, etc. That trend is going in the opposite direction. And what we need to do, and this is what I hope will be on the agendas, both health-wise, but also politically, is that we need to deal with the risk factors. And those risk factors, to address those, are the same agenda as we need to do with also ensuring that we have a more positive development for our climate. Energy, food, urban planning, those are the negative trends that are affecting our climate, and is also affecting people's health. So I was delighted to be engaged also with Selena on something we call Health of Societies for Healthy Populations, meaning creating opportunities for people to make more healthy choices. So I hope that will be both on the political, but also on the health agenda for us working on health in different ways across the world.
Wonderful. And I always love hearing people speaking about non-communicable diseases, given that's our area of focus in terms of our centre. So great to hear about that. Now, you've had such a rich and diverse career, but most recently in 2020, you became the head of the Secretariat of the Independent Panel for Pandemic Preparedness and Response. I was wondering if you could share some reflections on the Independent Panel report and what role panels such as these play as governing mechanisms in times of crisis.
I think this was a panel then co-chaired by former Prime Minister Helen Clark and former President of Liberia, Ellen Sirleaf Johnson, and then we had 11 panelists. And then I was heading a secretariat with a team, 10, 15 people, and then quite a big group of PhD students from across the world. I think really the strengths of this panel and how such a panel can be useful was that we combined evidence research and policy making. So we had a very sort of back and forth dialogue in between the researchers going through the evidence, everything what happened basically hour by hour during the first 3 months after the first cases in Wuhan in China, how China reacted, how WHO reacted, but most importantly, how the countries around the world reacted. So we basically got all the facts on the table and then interacted with a panel that was really top-notch senior policymakers, former presidents, former Minister of Foreign Affairs, former heads of or responsible people for health, etc. And I think why we got quite a lot of traction and attention for the panel's work and conclusions and recommendation was because we were able to combine the knowledge of politics with also research and evidence. And also that we spend quite a lot of time on the outreach. So we had one former ambassador to New York and one former ambassador to Geneva that basically helped us or worked with us really to do the political outreach. And that helps. And we got, I would say, an enormous positive response on the conclusions and recommendations of the panel, and also that the report was not written like a normal UN report, but it was written in, I think, a little bit more convincing way. But that was on the positive side. On the negative side is that this is now almost 2 years ago, the panel came up with 5 main, quite straightforward recommendations, but still a very tall order for the world actually to take action on. So the panel came up now with a report after 1 year that was called Transforming or Tinkering. And basically the message is that the world is still tinkering. I mean, now basically as we speak, they are meeting in Geneva to negotiate the pandemic treaty. Very slow progress and a very complicated agenda. I'm fortunately not very optimistic. We're going to have a high-level meeting in New York to try to agree on an agenda for the future next year, also moving very slowly. It's decided, but negotiation on that political declaration will not start until June, July next year. So we have a political environment where health diplomacy is more important than ever, but it is quite a tough environment right now.
Oh, that's really interesting to hear, and a little bit concerning if things are moving so slowly. And I'm interested to know, given that we are seeing growing forms of inequity, some due to the state responses on COVID-19 measures, I guess more broadly, how can global health diplomacy help to rebalance some of that inequity?
I think, I mean, I heard Mohammed Pate being a bit concerned about the term, also talking about global health, as that's been a bit sort of from above and not for people. And I think how global health diplomacy or health diplomacy can be more useful. One thing that I think is very important right now, that is to recognize that we have more of regionalization of health. We have stronger regions. And especially the region that Mohammed is coming from, he's the former minister from Nigeria. What we've seen happening in the African region with African CDC, African Union, taking much stronger prominence in this. I think the role for what we do at the global level is changing. So I think we need now to recognize stronger national governments, but also stronger, especially political regional bodies. So the old sort of paradigm that things were in some way solved from the global level and we created a new global fund basically to solve the problem. I think where we need to be more, what should we say, smarter and work in a different way is actually to work now with those regional entities. I've been involved now with developing a new strategy for the European Union for global health. And it's very clear, a different agenda in terms of content, basically trying to cover all those pictures that I showed earlier here, but also a strong message that this is no longer about us helping you. This is us working in partnerships with other regional entities. And also, this is no longer about aid. This is about then leveraging from the Europe side, our different instruments, whether it's on the food side, the energy side, the climate side, and to engage in recognizing that there are still things that we need to do jointly at the global level. But that agenda, and I think that it needs also to influence the political agenda. So again, this meeting in New York that we're going to hopefully have an agreement on how we need to change the international system to prevent having the same kind of disaster we have had this time. There are certain things that we need to agree to do jointly at the global level. Sharing information, the alarm system, sharing information about new tools like vaccines and diagnostic, and having a better flow of the access, having a more effective financing to be complementary to what we are doing at the global level, but also having hopefully a better political dialogue at the global level to basically to solve issues rather than to create issues. This was a key lesson from the panel, that the geopolitical situation has not been helpful. So we need also at the global level to have senior leaders that comes together and are helpful in situations of crisis. So I think one needs to take in reality, stronger national governments, but also working with the regional entities, and then to think what are then the functions, what we need to do at the global level, and that needs to influence also our agenda for that work.
That's really interesting. And I think a question that was posed in the earlier session from Helen Evans is probably relevant here as well. It's whether you think that the rise of nationalism combined with increasing national debt will inhibit progress on global health diplomacy and its priorities. And what can we do to minimize this?
Big threat, big problems. I mean, as I said, when we did the work of the panel, we saw, of course, what happened in between the US and China and their threats also towards WHO. But what we see right now, I would say, is even worse. So it is, that's part of the sad reality. But I think the only thing we can do is to continue to work, to be passionate about working together, believing in the multilateral system, doing exactly what you are doing now in Australia to mobilize people, communities, civil society organizations, researchers, and politicians. So I mean, to engage parliamentarians and recognizing that we can't solve those kind of issues alone. When countries think that you can solve a pandemic only by managing your own populations and thinking that you can, I mean, New Zealand might be an exception, being or possibly even Australia being islands and a bit not connected or having borders directly to other countries, but still you are very much part of the world as well. So no country can do this. So I think that's to continue to do that. And to, I mean, my hope is still that health is an area that we could have an agreement on. I mean, still, even if many leaders are still sort of trying to fight against working together and sharing information and trying to close borders and not having political agreements, still people care about people, caring about people's life and people's health. Not everybody, but the majority do. And I think we need to build and to work on that.
That's some very inspiring words. And I've got one more quick question for you, and then I'll also be asking Dr. Eric Gooseby also for some reflections. So get ready. But my final question relates to WHO. And I know that you've got a background working with WHO as part of your career, including stepping in as WHO Director General overnight due to the tragic passing of Dr. Lee Jong-wook. In your view, what role does the WHO have over the next decade, and what trends or challenges do you foresee for it?
I think WHO has a critical role to play in being the neutral partner here that can really share with the world what is really the situation. So the integrity of the organization to be able, I mean, if we again speak about the pandemic, to share information rapidly if something is happening. Today, WHO, according to the international health regulations, they need to get approval basically from the concerned countries before they can share information. I hope that WHO in the future will be empowered by Australia, by New Zealand, by Sweden to say, now we have something suspected. Then they can investigate. Then they should be allowed to come to countries with expert mission, basically to share with the world. So the integrity of sharing information about the health situation, but also bringing together the world's expertise. Also sharing then best advice. What should we do? What shouldn't we do? What drug to use? What strategy to use? What experience do we have across the world? But also including on some of those broader policy issues. Is it a good idea to have a tobacco tax or not? What are the implications of that? What can we learn in terms of some of the policy options we have? So I see that very much the future, what we need in the future in terms of still global functions are those functions. Challenges I see is that WHO right now have a tendency to move more into the more downstream operational work, quite keen also to be part of delivering stuff, goods, drugs, equipment at the country level. And I don't think WHO should be doing that. They should really stick to the technical work. That doesn't mean that WHO should have quite a strong footprint in countries where needed, but from a technical point of view. So I think WHO has some thinking to do in terms of strategic direction, to really to focus on the quality of the technical work. Because again, some of the challenges, if you move around the world, the quality of the technical work across the world varies when it comes to how WHO is performing at the country level. And I think that's where the focus needs to be. Excellence in terms of the technical quality that WHO is delivering. And I think that's really one of the critical functions when it comes to the international system for health in the future.
Thank you. And we heard earlier as well from Dr. Lowe regarding the importance of trust and WHO's role. So that's really important messages. Now I'd like to draw in Dr. Eric Gooseby and ask for your reflections on the future, and perhaps also noting one of the questions that we've got in the chat here from Sally Fawkes, which I might direct towards you as well. What do you see as the major push, pull and drag factors for the forms of global health diplomacy that hold most promise for human and planetary health? Over to you, Eric.
Let's see. Thanks, Haley. I can't seem to turn on the video for some reason. It says that the host has to allow it to occur. So I'll just speak to it though. You know, I think the challenges that are in front of us I think the ambassador's discussion about universal health coverage is what made me reflect on this. The importance of having a delivery system that has already developed a relationship with the population, with an individual, jumpstarts your ability to tell them about a new disease, describe a new threat, have the time and openness on part of the person to be willing to hear strategies to minimize exposure and spread. And I think that it has been further repeated the importance of primary healthcare systems, in that those who got in front of vaccinations and therapeutic interventions for COVID also were those who were connected to a primary care delivery system. It's an obvious point, but it's one that we need to take to heart. That universal health coverage is still far from being in place. And the gradients or currents that are working against our ability to see the healthcare delivery system as something that people should have access to, are entitled to, is a basic human right, is being eroded by the shift into a profit-making business investment that healthcare has become in so many developed settings. I could go on for a long time trying to explain how the discussion in San Francisco, the Bay Area, the state, and the nation around the COVID response was confounded by the decentralization of people's healthcare. Who pays for it? 85–90% of the people have private health insurance that the third-party payers in the health insurance in the United States did not feel that a pandemic threat and responding to it was their part of the agreement. They felt that when the person got sick and needed hospitalization or treatment, that's when they would come in. And it took 3 months in San Francisco to get the third-party payers that cover 92% of the insured people in the city to put themselves in front of the prevention, education, and testing needs that quickly became central to the response. So I would say that primary healthcare is still very much on the agenda for pandemic preparedness and for an effective response that can reach the populations that are most vulnerable quickly.
Thank you so much, Eric. Now, unfortunately, I think we are now out of time from this session, but I'd really like to thank Ambassador Anders Nordstrom and Dr. Eric Goosby for joining us for this discussion. I think we've got some really hopeful messages, as well as a lot of work to be done in terms of global health diplomacy. But thank you so much for your time, and I'll now pass back to Selena and the team for closing.
Thank you so much, Hayley. And Anders and Eric for that fitting end to what's been an incredibly enlightening and enriching conversation and Congress. When I first moved back to Australia, some people overseas, I won't tell you who or where, told me you can't do global health in Australia. Well, I think the richness of this discussion has proven that to just be simply untrue. This conversation we had today, the linkages, the voices can really only be had in this region, these ones. And in fact, at this critical juncture in Australian history, in global health history, and with all of its partnerships, threats and opportunity. So with that, I want to thank all of our panelists and chairs, and I'd like to hand over to Professor Jane Fisher, who's the Deputy Chair of the Alliance, Finkel Professor of Global Health and Director of Global and Women's Health, School of Public Health and Preventative Medicine at Monash University, for closing remarks. Thank you.
Thank you very much, Selena. And I'd be grateful if my video also, like Eric's, could be released so it could be turned on. But while that's happening, I think we've had a quite extraordinary opportunity this afternoon to learn about what global health diplomacy means from an astonishing group of expert presenters. That we've been reminded of the importance of needing shared solutions to shared problems in order to achieve health equity. And that to do this, we have to consider human rights, decolonisation, foreign policy, how to decarbonise, democratise all policies, and to take into account the work of multiple agencies, some faith-based, some non-state actors, civil society organisations, understanding who the key players are and what the lines of accountability need to be. And these are intrinsically extraordinarily complicated things to do. So I thank all of the presenters this afternoon who've talked to us about new ways of thinking and new ways of doing that will influence the spheres of operation of all the participants who've come this afternoon to have the privilege of listening to each of you. So I thank very much Ian Anderson, Eric Goosby, Stephanie Williams, Mohammed Ali Pate, Ying Ru, Jacqueline Rowe, Thomas Kai, Jennifer Tierney, Renzo Guinto, Kath Chamberlain, Kim Allen, Anders Nordstrom, Hayley Jones, for taking the time to distill your thoughts into brief presentations that have been immensely enriching for the many participants from many countries who've been able to join this forum. I also want to thank in particular Selena Lowe, Piali Somai, Abby Minter and Georgina Warwick, who've not only provided technical support to enable this to happen, but have done a remarkable job in conceptualizing it and in bringing many players, many people together for this quite extraordinary afternoon. We also want to acknowledge the work, the voluntary work of our chair, Brendan Crabb, who apologises for being unable to be here, Helen Evans and Matt Ralston, who are the members of the executive of the Global Health Alliance, and the diverse members of the advisory board who support and enable its activities. You will have seen Jessamy G working in the background from Think in Colour to produce a real-time infographic that will ultimately be available to remind us about what it is we've learnt this afternoon. So I'd like to close by thanking all of you for your wonderful contributions, and I look forward with Selena to a future forum where we revisit some of the important things that were identified today. Thank you, Selena.
Thank you to everybody, and have a safe end of the year. And if you're interested in the work of the Alliance and the WHO Collaborating Centre Network, please join us on our websites and join our emails and our newsletter subscribing. We leave you now, and thank you.